Morning, everyone. So today's talk is going to be about the adolescent varicocele. Throughout the talk, we will tackle on these objectives. Number one, to review the definition, causes, and pathophysiology of varicocele. To discuss the clinical dilemma in adolescent varicocele and why they are considered special age group in this, dealing with varicocele in this age group. To review indications and management. Start with varicocele definition. It's an abnormal dilation and tortuosity of the gonadal internal spermatic veins, or at a lower level, which is the pampiniform plexus. There are many theories as to the etiology of varicocele. One of them is the valve incompetency, which is basically in order for the blood to go unidirectional from the testes back to the core of the body, we need a competent valve. In cases where there's incompetency in these valves, or in some cases the absence of these valves, they found that they have higher incidence of varicocele. Another theory, which is basically the anatomical variation. We all share more or less the same anatomy, but this might explain why the left varicocele is more common than the right side, because of the way the left testicular vein is inserted into the left renal vein in a acute angle comparing to the right testicular vein. This is number one. Number two is that the left testicular vein is under higher pressure compared to the IVC, and that's why the left testicular veins tend to engorge or have a higher hydrostatic pressure, presenting as a varicocele. Now, a less common yet better understood etiology is what we call it nutcracker syndrome, which is basically the way the left renal vein passes between the aorta posteriorly and the SMA superior anteriorly. If these SMA emerge from the aorta in an acute angle, that might compress the left renal vein, which causes the back pressure to the veins that it drains into the left renal vein. One of them is testicular vein. Now, the varicocele pathophysiology, before we talk into the theories, which are actually speculated how varicocele induced testicular damage, we should establish first that varicocele is a progressive and duration dependent, meaning the varicocele, if it's present today with time, the micro damage that happens in the testes might show later on rather than when it's presented. One of these theories, which is the most plausible theory, is the hyperthermia. Basically, as the blood goes through the testicular artery towards the testes, where there is a lower temperature, the heat exchange between the artery and the vein, allowing the microenvironment of the testes to be at a lesser temperature, which is an optimal microenvironment to enhance spermatogenesis and Hydrocele and Sertoli cell functions. However, and this has been also established in animal models where they induced a surgical varicocele. So they tied the left testicular vein in rats, dogs, and primates, and what they saw and what they noticed is that the temperature in the scrotum was actually, or in the testes, was actually higher in those who had a varicocele comparing to those who do not. Combining the hyperthermia theory with the reflux of renal-adrenal metabolites, this causes oxidative stress at the level of testicular microenvironment, impairing the Hydrocele, Sertoli cell, and the growth of the testes. The way they present in pediatric, usually either pain or scrotal swelling, while in the adults, yes, they present with pain or scrotal swelling, but the more common and more concerning is the fertility issues. Now, the concern of varicocele in pediatric age group specifically is that with this progressive time-dependent damage, with time, it might affect fertility, and that can be reflected by the semen analysis and the decrease in testicular size, and more or less with the endocrine effect, which we'll explain about it later on. Now, let's compare adult versus the pediatric varicocele and what's so special about the pediatric or adolescent age group. Initially, let's talk about the prevalence. The prevalence in adults is 15%. However, in the pediatrics, it depends. If we are talking about less than 10 years age group, it's quite rare. But 15 to 19 years, it actually resembles the adult, the prevalence, which is 15%. Now here where the actually clinical dilemma, actually, we can elaborate more on it. Even though in the adults, it is the second most common cause of infertility. However, 80% of those patients, of those population with varicocele have no fertility problem. So meaning only 20% of those varicocele have a fertility problem. So if we want to apply this into the pediatric age, it's quite difficult because when in a clinic, if an adult patient presented with inability to conceive or infertility or subfertility, so he is by default under the category of the 20%. However, in the adolescent, which is majority of them not even sexually active, and some of them are quite young, 14, 13. So how can we infer this age group or these population, whether they are under the 80%, which has no problem with it, or the 20%, which have fertility problem? So that's where they start to find what might predict a fertility or, in broader term, testicular dysfunction. So they have studied varicocele as an indicator, or where we can label those population of varicocele adolescents under these 20% or the 80%. They studied testicular volume, ultrasound venous study, and hormonal studies. So let's start with the varicocele grade. So varicocele grade has been established by Dubin and Amelar in 1970, where they labeled or they grouped the patients with varicocele that is palpable at Valsalva only as a grade 1, those without Valsalva but not visible as a grade 2, and those who are easily visible at distance, which is the classic bagiform appearance, as a grade 3. Now, before we even test or comparing, or even test the varicocele grade as a predictor of fertility or testicular dysfunction, the problem arises early on when Hargreave in 1991 did a study where he let two experienced clinicians assign a varicocele grade to a group of population or group of patients, and what they found is that 20% disagreement between assigning grade 3 and grade 2 or grade 1. And this is actually a problem because if we cannot accurately assign a patient into a certain category, how can we predict the future fertility problem, or we can use it as a predictor of testicular dysfunction? However, still they did a study, this is a quite powerful study done by Dr. Diamond in Boston Children's Hospital. This paper has been cited in American, European guidelines. So what he did is actually he wanted to find a relationship between varicocele grade and testicular hypertrophy to semen parameter in adolescents. So he collected the semen of 57 boys that already reached Tanner stage 5, and an attending urologist assigned a varicocele grade, and a sonologist assigned the testicular volume. Before we go into the details of this paper, let's just review quickly the semen analysis WHO 2010. The semen volume normal lower reference is 1.5 ml. Sperm concentration is 15 million per ml. Total sperm number is 39 million per ejaculate. The motility is 32%. Progressive, non-progressive combined should be 40%. Vitality 58%, and normal morphology 4%. To find a better predictor of a spontaneous ongoing pregnancy rate, Smith in 1977 calculated what we call total motile sperm count by multiplying volume to concentration to motility. And according to him, is the total motile count is actually a better way to label a quality of sperm rather than relying on the WHO semen analysis. And Hamilton, 2015, established a cutoff of 20 million motile sperm per ejaculate as a measure of a good quality of a sperm. And the reason why I'm mentioning this, because this is what actually Dr. Diamond applied in his paper. Now back to the Dr. Diamond's paper. Basically, what he did, he grouped the patient to grade 1, 2, 3, and then plotted against the semen parameters, the WHO 2010, along with the total motile sperm, which we have already talked about. And what he found is that grade has no association with the semen parameters, and there is no statistically significant difference between each grade, meaning we cannot label as the higher the grade, the worse the semen parameters, or as a reflection of semen parameters. And that is actually held true in the adult literature. If we review the grade versus the semen quality in adult literature, we found that there is no clear association between each group against the semen analysis parameters, but varicocele as a group, I mean, comparing varicocele people without varicocele, there was a poorer semen quality overall. But comparing each grade, there was not much correlation in between. The second reference I reference here is actually they tested the severity of DNA fragmentation, sperm DNA fragmentation, and again, there's no correlation in that. So far we can at least label as the grade of varicocele cannot predict the testicular dysfunction. So the next predictor they try to find is the testicular volume can be used as an indicator. So back to the study by Dr. Diamond again. Now we will compare the testicular volume or hypertrophy to semen parameters, and this is what he actually found. He grouped the patients into 10% difference or 10 to 20% difference in testicular volume or more than 20% of testicular volume. There's a simple equation, not too complicated to find this difference. And then he plotted this findings against the semen parameters. And then he found there is a statistically significant difference in sperm concentration, motility, not so much with morphology. And the last thing is the total motile sperm. And the last category, which is the total motile sperm, he plotted in this diagram just to elaborate more how the testicular volume difference reflects the quality of the semen. So as the testicular volume difference increased from 10% to 10 to 20% to more than 20%, the good quality, which already established by Hamilton, which is the 20 million cutoff, starts to decrease from 85 to 67 to 33, and it is statistically significant. And comparing to the poor quality, which let's say less than 10 million total motile count, in the 10% testicular volume difference, it didn't show any. In 10 to 20, 11%, and more than 20%, up to 60% of poor quality of semen analysis. Lastly, in the same study, he did a multivariate analysis just to assess or test each parameter independently from each other. So basically, what he found is that the volume difference is actually showed statistically difference in the semen parameters in the volume difference, regardless of the varicocele grade. Now, people actually now happy that they have at least, let's say, established a 20% difference as a predictor. However, this has been challenged by two doctors, Dr. Cullen in 2008 and Batavia in 2010, where their theory is single reading of 20% difference is not enough to take a decision in clinic to operate or not to operate. So what they did, they actually kept follow-up patient with this significant testicular difference. So what Dr. Cullen did, retrospectively, he collected all of the patients or adolescents with left varicocele and with testicular volume difference more than 15, he used the 15 cutoff, who have at least 3 ultrasound follow-ups with 1 year apart. So he kept following up patient with testicular volume difference 15% for 3 years with 3 ultrasounds. And what he found is that 85% of the patient, of boys, which is 27 out of 38, actually had a catch-up growth, meaning the testicular volume became less than 15%. And this is actually true to lesser extent by Batavia, when he found that 1/3 of the boys with testicular volume more than 15 normalized within 22 months. Based on this study, which has been mentioned and cited by the European guidelines and the American guidelines, is that we don't rely on one single reading, which is the 20% testicular volume difference. We rely on couple of readings. And as per the European guidelines, they actually recommend to see the patient 2 more times within a year with 2 ultrasounds just to confirm that this patient is in that category who will not have a catch-up growth. Now, at this point, doctors were not happy relying on a single predictor, which is the testicular volume. So they further elaborate other predictors, which what we will see in next slide, which is the venous Doppler study. So what Dr. Glassberg did, basically, he wants to augment the decision to do surgery or to not with the 20% testicular difference. What other predictors that add to that in order to have a better decision? So what he did, he actually measured the peak retrograde flow, which is basically conducted while the patient is supine position. He generates adequate Valsalva. He gets 3 readings from the largest vein, and then he measures that number. And what he found by the end of his studies is that all of the patients who presented with 20% difference and peak retrograde flow of 38 centimeter per second and higher had a progressive asymmetry to follow up. So, and that has actually been true when this study got published in 2009. So he did another study or just a complementary study to increase the volume of his patient. And in 2013, he published another paper with the same principle. And what he found that all the patients who were having 20% testicular volume difference and 38, the peak retrograde flow was 38, there were 140 boys. 85 of them already chose to undergo surgery. However, 44 boys wants observation. And what they found is that those who have, from the beginning, the 20% difference and the 38 peak retrograde flow rate, roughly around, let's say, 68 plus 70, which is 93%. So 93% of his population who presented with 20% difference and 38 retrograde peak flow rate to have a progressive or persistent asymmetry. And only 3 boys, which is 7%, have less than 15%, which is, at least to his paper, is a catch-up growth. So by that, he concluded that we can use the venous Doppler study as to augment our decision whether to rely to only 20% difference or to combine these two. However, this finding has been mentioned in the guidelines. However, they did not recommend yet to use it, probably because of this single 2 studies by the same guy. So again, doctors were not happy to rely on single parameters, so they trying to find another thing. This is a quite stretch, which is the hormonal profile. This came based on the finding in the adult that when they took testicular biopsy from the adult population with varicocele, they find that there is histological changes on the level of Leydig cell hyperplasia, decreased number of Sertoli cells, and spermatogenesis arrest. So what they thought that this must be reflected by the hypothalamus pituitary testicular axis. So there must be some hormones actually influencing this changes. So they studied the LH, FSH, and inhibin. Even though some results showed promising, even some studies showed promising results in terms of FSH and inhibin, but there is no current consensus on the utilization of these hormones, at least in the adolescent age group. Even though some papers have been published in the US centers where they use the FSH and inhibin as to augment the decision whether to do surgery for a 20% volume difference or not. After all of this evidence, let's just summarize the predictors. So far, the varicocele is not a good predictor. Testicular volume, or rather the progressive loss of testicular volume, was a good indicator. And of course, we don't rely on one reading. We rely on a couple of readings in a period of time. Ultrasound still is questionable, promising, being recognized by the guidelines, however, no recommendation yet. Hormonal analysis is still a bit far from the ultrasound venous study. Now let's talk about the indications for intervention. At least as per the European today, or 2025 guidelines, the absolute indication is that total volume difference more than 20% with confirmed by 2 more readings 6 months apart. So basically, if today you have a patient in your clinic with 20% volume difference, you follow him up for 1 year, you see him twice with 2 ultrasound, just to make sure this 20% is actually persistent. The relative indication is pain. And the reason why they keep it as a relative indication, because number one, they found that 20% of patients who underwent surgery have a persistence of this pain. Number two, there's no clear correlation between pain and varicocele. Another relative indication is bilateral presentation. They did not elaborate much on that. And the last one is pathological sperm count. And this is because it's very selective in our age group, the adolescent, because the sperm analysis, the WHO 2010, is only applied for those who have already reached Tanner stage 5. So, and our patients, not all of them already at that stage. This is number one. Number two, the difficulty of requesting semen analysis in this age group, whether it is cultural, religious, or parental preference. And this is reflected in the literature as well. Now, the treatment goals, we want the resolution of varicocele and hopefully without recurrence. We want to improve the testicular growth after the intervention. We want to improve the semen parameters for those who were able to collect semen parameters. And if they are underwent the surgery because of pain, we want the pain to be resolved. So basically today, if I encounter a patient or adolescent with a varicocele, my options are these. Either I can monitor the patient, or I can offer him surgery, and there are multiple techniques, either open, microscopic, inguinal, subinguinal, and I'll elaborate that more in the next couple of slides. And the last option is actually done by the intervention radiologist, which is the non-surgical approach, which is the embolization. First, we'll talk about the subinguinal and inguinal briefly. So the difference between, so it's basically the principle is delivering, tying off the dilated veins at the level of spermatic, at the level of the inguinal or subinguinal, which is now it's the main difference between inguinal and subinguinal is basically the location of the incision, the anatomy encountered, and the associated trade-offs with post-operative pain and surgical difficulty. This is a procedure, whether subinguinal or inguinal, it can be done with or without magnification, hence the terminology conventional varicocelectomy or microscopic varicocelectomy. In this image, you can see this is the conventional one. You can just appreciate the veins by the naked eyes. And this image actually showing the microscopic where you can actually appreciate the testicular artery, tying off the veins and sparing the the lymphatics. Well, in terms of, okay, surgical, yeah, subinguinal, at least in the adolescent or pediatric age. They're usually more comfortable with the inguinal approach rather than that's. I'll explain what's exactly the practice currently in the world. Now, the Palomo technique, which is the retroperitoneal approach, we can do it either open or lap. Which basically this technique is the ligation at a higher level, at the level of spermatic vein and artery altogether, and that's the original Palomo that they do, or he did a massive ligation of veins and artery. Some modification has been emerged in the literature, which is the lymphatic sparing or artery sparing. And the concern in this technique, theoretically at least, the testicular atrophy, because we are clamped or because we are ligated the artery, and the hydrocele secondary to the mass ligation without sparing the lymphatics or anything. The third last approach I'm going to explain is the non-surgical approach, which is the embolization. It can be done under local anesthesia. I'm not sure how is that applicable to the children or the adolescents. The downside is that it involves radiation, and it actually embolizes the internal spermatic vein through the femoral vein axis. Now, this is how the practice in the adolescent age group. In the US, the two most common techniques are still the Palomo, whether it is the open technique or the laparoscopic approach. Radiographic embolization is seldom used in the primary repair. Antegrade sclerotherapy is widely used in Europe. Pediatric urologists are less likely than andrologists to use the microscopic approach, and that's the current practice. Now let's compare whether should I offer intervention or keep observing those who have varicocele and 20% testicular volume difference. So this is the best quality of evidence currently we have. It's actually a meta-analysis, a huge meta-analysis published in 2019, conducted by the European Association of Urology and the ESPU, which is the Pediatric Society in Europe. They included 12 randomized controlled trials, 47 non-randomized comparative studies, and 38 single-arm case series with minimum 50 participants. Any child or adolescent less than 21 years with the varicocele included. So they have a total number of 16,130. And then they include all type of management, whether it's surgical, inguinal, subinguinal, Palomo, laparoscopic, radiographic embolization, and observation for head-to-head comparison, which I'll explain later on. Their outcome is beneficial outcome in terms of testicular catch-up growth, improvement in semen parameters, and the resolution of this varicocele. The harmful, which is basically the complication, is testicular atrophy, hydrocele, and recurrence. Now, when they compared the intervention versus observation, there is only two parameters that are actually statistically significant in terms of offering intervention or keep on observation. So in this comparison, which is the testicular volume, they compared 4 randomized control trials. And what they found is that there is a statistically significant difference between the mean of after the follow-up, the mean testicular volume in ml. There was a significant difference between intervention and observation, with the mean difference was 1.52. Now the question is, this 1.52 ml clinically significant? That's they did not elaborate on, because it seems quite not too much, to be honest. Apart from testicular volume, the only parameters that they noticed showing statistically significant difference is the total sperm count. When they compared these two randomized control trials, they found that there is a mean difference of 25 million, and it showed the statistically significant difference. About the rest of the parameters, which is the motility, morphology, there was no statistical difference comparing intervention versus observation. Now let's compare intervention versus intervention, meaning let's compare the technique or approaches of intervention and compare it to a certain outcome. So here they try to compare different techniques in terms of catch-up growth. Before I talk about the RCTs, in general, the catch-up growth after the procedure is quite high, whatever the intervention is, but what they want to elaborate is the different technique shows a different catch-up growth. And what they found in 2 randomized controlled trials, Shirashi found in 2016 that offering inguinal or subinguinal would not have any statistically significant difference in the testicular volume after the intervention. And Mohseni in 2011, he compared the open retroperitoneal versus open inguinal, and again, there was no statistically significant difference. And this is also showed in the meta-analysis. That's in terms of catch-up growth. Now, in terms of sperm parameters, there was a single randomized controlled trials that compared the testicular artery sparing versus non-sparing laparoscopic varicocelectomy, and it's done by Zamperini in 2007. And what he found, that after offering the surgery, which is sparing or no sparing, he elaborates the semen parameters. And what he found, let's focus the numbers in between the brackets. He found that in non-sparing group, the volume was 2.8 after the intervention, and in the sparing group, the volume actually was 4. In sperm concentrations, 58 to 73, 39 to 54. So basically, all of these are statistically significant difference. The problem with this study is that they did not elaborate the semen analysis prior conducting the study. However, they did not mention the exact numbers. However, they just mentioned in their script that there is no difference in dividing the patient with abnormal semen parameters between group A and B. The third outcome, which is the pain resolution, in that regard, comparing intervention to intervention, which is inguinal versus subinguinal, again, this is the only randomized controlled trials done by Shirashi in 2016. He found that there is a complete resolution in both arms. Now, non-comparative studies, just to elaborate the efficacy of pain resolution, he found that Keane and Cavilli in 2017 found that the pain actually resolved in all patients with antegrade sclerotherapy. And in 2000, the pod just compared the laparoscopic or shared the laparoscopic varicocelectomy outcomes, and he found that 92% of the population actually have a resolve of this pain. Now, the last part of the comparison is the complication or the harmful, basically the recurrence rate. So in this meta-analysis, again, it showed that there is comparing the open surgery versus laparoscopic. There was no any difference. The data were all over the place. The odds ratio actually crossing the 1%. So there's no favoring in terms of recurrence, laparoscopic or open surgery. This is the only comparative study. However, reviewing the literature, whatever the reference you will use, this is just numbers reflecting percentage of complication in these procedures. For example, in microscopic inguinal, the recurrence rate was 2.5% of the procedures. The subinguinal was 2.1. The highlight in this is that the radiological intervention, whether it's angioembolization or sclerotherapy, has a higher recurrence rate compared to the rest. And interestingly, the LAP artery sparing showed a higher recurrence rate comparing to the rest of the surgical techniques.
Just a quick question here, sorry.
Yes.
Are any of these, I may have missed it, but does any of the studies compare observation to intervention, even in a non-randomized way? Or is it all comparing intervention to intervention?
No. Initially, I talked about the observation versus
Observation versus
and
intervention,
only
but
two parameters were actually useful:
and they
is
were
the volume
okay.
and the total count. Okay. Now let's talk to the second complication, which is the hydrocele formation, which is the most common complication in regards of as a complication of these interventions. The only comparison was lymphatic sparing versus non-lymphatic sparing. So if you want to, and their conclusion is that there's a statistically significant difference if you do the lymphatic sparing compared to non-lymphatic sparing in hydrocele formation, which is less basically. The odds from, let's say, 0.01 to less than 1 or... now, back to the literature review in terms of the rate of hydrocele formation. Again, non-comparative study. The highest hydrocele formation was in the mass ligation and the laparoscopic approach, mass ligation division, which is the classic Palomo technique. The rest of them is, and also the lap artery sparing also showed higher than the rest of the other surgical techniques. Apparently, the intervention has no concern in regard of hydrocele formation, but they have high recurrence rate. So that's a clinical decision based on surgeons whether to proceed with this or that based on these numbers. And the last thing, which is the testicular atrophy, unfortunately, there was no head-to-head comparison in terms of testicular atrophy. However, and even in the literature, the percentage mentioned in the paper that in the systematic review that I found, they only labeled the microscopic inguinal had a 1% chance of testicular atrophy, the subinguinal is 0.5. The rest of them, there's no much data in the literature in terms of the testicular atrophy in the adolescent age group. So in conclusion, our take-home message is actually pain and testicular volume difference confirmed with cellular measurement are the indication for repair. Intervention showing promising catch-up growth and improvement in total sperm count compared to observation. Lymphatic sparing techniques are a better option to prevent hydrocele formation if you offer them intervention. And thank you very much. Yes.